Thank you, and welcome to the house that Herb built and named so generously for the great class of 1962. And I'm with these guys, but I am not on their level. I'm not sure many people in this country or world are. If you haven't read their biographies in detail, we heard from Dick, who has done so much, by the way, for this reunion. If you haven't read their resumes, I recommend you do not, because you probably are feeling pretty good about your accomplishments, but if you read those, you realize you've wasted your lives. We're here to discuss the rather academic title of Perspectives on Healthcare and Public Education. They didn't call me, since my Fox News background would have changed the title to Sick or Stupid, You Choose. And since I'm from Fox News, it would have been Sick or Stupid, You Choose, and Why Obama Won't Let You. We don't have a lot of time, so I want to get right to it. And because I'm not an expert on most anything, but particularly on healthcare and medicine, I've talked to a lot of people before talking to you guys. And I get from everyone, both sides of the aisle, their feeling that something has gone wrong in both healthcare and education. We all know about Obamacare, but I know, Toby, that you think the revolution in medicine is already going on. Is that correct?
I do. First of all, let me say how pleased I am to be here. I've said on several occasions that you are the most diversely capable and distinguished group of people I have ever been associated with, and I feel that way today, and you're probably one of the most distinguished and thoughtful group of people I'll ever have a chance to address, so it's a real pleasure to be here. Let me talk a little bit about medicine, sort of past, present, and future. First of all, the past. Everybody says that the United States healthcare system is broken. Just so you know, we have the finest healthcare in the world, but it has problems. The problems are really sort of in three parts. First of all, access, and with 50 million people not being covered. The second problem is quality, which is variable across the country and is not transparent. The third problem is the cost. We have the highest costing healthcare system in the world. And so the Reform Act, or better known as Obamacare, was designed to handle those three things. And it did well in some and not so well in others. As far as access is concerned, I think you have to give it an A. 30 million more people are now going to be covered. As far as quality is concerned, it probably gets about the sort of grade that I used to get at Williams and cherish, a C+. And as far as cost is concerned, it's really going to get an F, because we're going to see escalation of healthcare costs, and it didn't really do very much to contain the healthcare costs. So, there are, back sort of now to the present, and the present concerns what's going to happen with the Supreme Court. In the Supreme Court, I don't think any of us have insight into what the Supreme Court will decide, but my thought is that it really doesn't make a difference what the Supreme Court decides, and probably little difference regardless of who is elected president and what happens in the houses of Congress. And the reason this is really twofold. First of all, the demographics that are at work right now are going to see the baby boomer generation bringing many, many more people into the healthcare arena in terms of need. 10,000 people a day are now going into Medicare. And by 2020, we will have 55 million people in the United States greater than 65. So we have a huge bolus of people coming into the healthcare needs. The second portion of that is cost. Right now, the deficit or the obligation total for the United States is about $60 trillion. $30 trillion of that is related to Medicare. So we will not address the debt in the United States unless we address the cost of health care across the United States.
And you're doing something about that at the Cleveland Clinic, aren't you?
We're trying.
What are you doing?
Well, it gets micro in lots of ways, but one of the things that's interesting about the Cleveland Clinic is that if you look at the top 10 hospitals in the United States and look at the cost of the last 18 months of life, where most of the cost of healthcare is, there's two institutions that have the lowest cost, and those are Mayo Clinic and Cleveland Clinic, which are within a fraction of each other. And one of the things about them is that we have the same sort of model of care. All the doctors are salaried. And it doesn't make, we have no advantage for doing more, or on the other hand, for doing less. And so the number of tests that you get, the number of operations you get are held to a minimum and trying to drive efficient care. And it's coordinated. All of us, all 3,000 of us, are part of the same group. We work together, and it doesn't make any difference back and forth about where the dollars go.
And you think you can maintain the same level of quality?
I think we've done pretty well, actually, on quality. One of the things that, you know, I met one of my survivors the other day, and I was really pleased. If you keep at it long enough, you'll get one of those. Actually, seriously, one of the things that we did is we started about 20 years ago being very transparent about our results. And each year we publish quality outcomes books, which has been, and I've asked every department across the Cleveland Clinic to do that. And it's pretty easy in cardiac surgery to tell you what the outcomes are. Either you walk out or you get carried out. It's not quite so obvious in rheumatology or dermatology, but I asked each one of those specialties to say, you can't talk that you're a great doc and you got great results. You got to get some metrics and you got to show us and you got to be transparent about it. And that's a whole revolution in trying to drive quality.
You're essentially talking about money, at least part of it. And I know that Tom Payzant, who has such a distinguished career as a public educator, has run into those same money problems too. Is that the bottom line in education today or not?
Well, I think it's the bottom line in most public institutions, and I've been in 5 different superintendencies in different parts of the country. But given some federal policy that drives education in this country, most of the responsibility for determining what students should learn, the degree of rigor, the kinds of assessments that will be used, and hopefully there'll be some alignment among them, rests with the states. So you can imagine with the states, the way they are, that there's wide variation in terms of my sector of interest, education, in terms of the quality of the work they do, the people that they have in their state education departments, and how the bulk of their teachers and others for public schools are trained. So you don't have a national kind of standard that is going to be executed in the same way in a lot of states. So that leads for a lot of gaps. Yes, money is the big issue, and in many state budgets, and certainly in local school districts, schools, whether they be cities, suburban, or rural, are struggling right now, the 3rd year of cutbacks across the board in a way that I haven't seen in my entire career. The other thing that is consistent across most schools and school districts is that a minimum of 80% of a school district budget is for salaries and benefits. And in some places it's even higher than that. So you're constantly dealing with that on the one hand. The other question I get asked a lot about already in talking with several of you in the past day or day and a half is, what about unions? Well, there are union states and there are non-union states. Every one of the 5 states I've been in have had unions. I've gone through teacher strikes. I've gone through the whole range of things. But I'm not a union basher. Because when you're in an environment where there are unions, the only way that it's going to be productive for both sides is to work on each side understanding the other side's needs and figuring out how you can meet your middle ground, keeping in mind that in the arena of public education, at the end of the day, yes, the adults are important. It's the quality of instruction in the classroom, and second only to that, the leadership in the schools that will make a huge difference. But it's those teachers in the classroom, building the capacity in them to do the job, to provide them with the supports that they need to get better at what they do. So really, even in these times of cutbacks, you try to stay away from that classroom as long as you can. But the only options you really have, which is occurring in many districts now in the third year of cuts, is you can't cut all around the edges. You can't cut in half the central office. That's already been done. You have to go for teachers. What does that mean? That means raising class size. Now, for all of you who are there and say, class size is the most important variable, it's not. Quality of instruction in the classroom will trump class size all the time. A high-quality teacher with 30 kids in the classroom will do a better job than a poor teacher with 15, 18, or 20 kids in the classroom.
Tom, but when you have those large classes, to whom are you teaching? Are you teaching to the middle-level student? Are you ignoring the top-level student, not challenging that student, or perhaps not dealing with a student that can't deal with any of it?
Well,
how do you arrive at that standard?
Yeah, I think you have some differentiation at the levels, if you think about elementary school, middle school, and high school. So in elementary schools, it's really getting teachers who are not only good at understanding the curriculum, but understanding children. And from a policy perspective, one of the best things that we can do with research behind the argument is to start with high-quality programs for 4- and 5-year-olds and getting them off to a good start in their first year of regular school. And if kids are not reading by the 3rd grade, then it's downhill from there and a huge challenge. So those are some of the kinds of things you need to focus on.
In terms of cost, I know that Toby, and I'd like you to tell us more about it, has called for consolidated systems, you eliminating small hospitals and that kind of thing, and having, well, you're in 4 states, I believe, is that we're more, and having a bigger operation, saving costs that way. Can you do that since education seems so localized? Can you get those cost savings through any kind of consolidation?
Well, I come back to the big variable is salaries and benefits. And so the only way you can control cost is to, particularly if you're in union contract states, is negotiate in a way that you're not just always putting money on the table when it's not available. And that's not easy to do, but it is doable. And in terms of the relationship with the union, if it's a positive one rather than a hammering one, you may be able to get to the middle ground and get some concessions there. And in this environment, that's happening more than I've seen it in my whole career because it's the 3rd year of big cuts.
Just from a personal point of view, I'd like to know what you see as the major frustration of your career, Toby. We've heard about your successes. We know
Bleeding. I hate it. Well, you know, one of the issues I think we're dealing with right now is trying to deal with healthcare reform, and that is very frustrating because a lot of the individuals and the way the bill was fashioned really were not very receptive to input from anybody that I have talked with. And it was a very politically structured healthcare reform. And just parenthetically, I think we're just at the beginning of healthcare reform. We're going to see 10 more years of changing laws about healthcare reform, and we're going to see a whole change in how healthcare is delivered, where it's delivered, how it's delivered, the diseases we look after, and who pays for it.
And fewer tests?
Are we going to see fewer tests? We'll probably see fewer tests in terms of less regular mammograms, perhaps less common yearly physicals, that sort of thing, less redundancy. But I think what we really need to see is much more coordination of healthcare across the entire spectrum, and we can't get that with just like you had with corner stores, mom and pops here and there. It has to be coordinated across, and not all hospitals can be all things to all people.
And is it your sense that we're still getting the best and the brightest to go into your profession the way it was when you went in?
Well, hopefully they're a lot brighter than I am, but no, they're very, very good people going into healthcare. I think one of the big things about the people that are going into healthcare is there's a change now that has to be understood. Healthcare used to be the doctor carrying the bag solo. It's now gone from an individual sport to a team sport. And that is a huge change across healthcare. And you have to realize the reason for that is that the total amount of knowledge is doubling every 2 years. So nobody individual can keep track of it all, so you have to have a team.
Tom, on the teaching level, does that also apply? Is it a team sport or is it still an individual sport?
Oh, this is one of my real pet peeves that I never was able to really change in practice what would have addressed it. And that is the default culture in most public schools in America is the culture of isolation, where the teacher shows up in the early part of the morning, may have coffee, talk with colleagues for a little bit, goes into their classroom, closes the door, does the best they can with the children they have. And trying to move from that kind of culture to one where there is more teaming and groups of folks working together, learning from each other and taking responsibility as a team, that is getting some traction. And did a lot of work on that in Boston. Then it comes back to what kind of systems or structures do you have to provide the time for the teams to meet. So teachers often, in all of the districts I've been in, have some planning time during the school day. May only be one period or a 45-minute block or whatever. That's pretty consistent now. So what I did in Boston was we took one of those planning periods every day and put a group, a team of people together who met, and you can't throw teachers into a situation where they've had no experience with team and a lot with isolation, that we had to provide facilitators to help them become a team that then enabled them to focus on their work. And then the lever was, how are we going to get to focus on the work and make some decisions and not have the culture of nice take over? So what we said was we're going to use looking at student writing. And so a fourth grade group of teachers would come in at common planning time, they'd bring their kids writing, they'd read each other's, and guess what? If there were 5 in the room, there was a variation. There might be 1 or 2 that were getting top level, and 1 or 2 that were given in the middle, and maybe 1 or 2 lousy work. All the same kind of kids. No argument that you had the hardest kids to teach and somebody else didn't. And that really changed the way in which the thinking occurred. But we had to have a facilitator in those common planning times to get the teachers to a point where they understood how and wanted to take responsibility for the group. When you can do that, it helps change the whole environment of the school and challenges that isolation environment and gets people working together. It doesn't happen overnight. It took 18 months to get this really rolling.
Is it your sense that public education is better today, generally, than it was 50 years ago?
I think it is better for those who were neglected and written off than it has ever been. And I'm talking urban school districts now, because that's been pretty much my whole career. And there have been more opportunities for improvement for the kids that were left behind. And the standards-based movement that is very clear about what students should know and be able to do, and each state develops its own, and being held accountable for that. That yes, it's still not good enough. There still are major dropout problems in urban school districts that we haven't done a very good job in we've minimized it, but we haven't gotten complete control over it. So yes, better, but a lot of work left to do.
Toby, in healthcare, there is a perception, particularly in New York City, where I happen to be from, that healthcare is great, but it's a lot better if you have a lot of money. Is that not the case?
Gee, I think that may be very unusual for almost anything. Yeah, I think that clearly the resources that you have available do make it easier to have great care. One of the things that I'm always asked about is, well, the Cleveland Clinic just looks after kings and queens from all over the world and people with lots of money. It's interesting that we have the same mix across our 1.25 million patients that we saw last year as is the norm for our geographic distribution. So Medicare, Medicaid, no pay, private pay, insurance, et cetera. So we're able to do this. And I think probably the most important thing is that we're going to have to do is drive the organization of healthcare. And you stop and think about the history. Really, healthcare, every community was responsible for its own healthcare. They all had their own hospital. They had the doctors that worked there.
It's kind of like every community is responsible for its education.
Exactly the same. But it's gotten to be now so that all these community hospitals can't have all the technology. And for the really rare things, there's not enough of it practice to have people be good at it. And it's just like, putting. The more you do at it, up to a point, the better you get at it. And so you practice. And so if you're going to be doing something regularly, you're going to get more efficient at it, and the quality is going to be better. So just an example. We have 9 hospitals in Cleveland. 6 of them did obstetrics. And we now have 2 hospitals doing obstetrics. The quality has gone up. The number of deliveries has gone up. And it is just simply because of the practice of doing that. We did the same thing with trauma. We consolidated from 6 hospitals, or 5 hospitals doing trauma to 3. As a result, the time to get to the hospital increased by 5 minutes, but over the course of a year, it saved essentially 118 lives because they were going to trauma centers that were better at doing it. So you cannot expect every hospital to do everything.
Is there a corollary in education at all?
Well, I think the biggest difference may be, although on the front end maybe Toby would say, no, it's like your arena as well. But choice systems. Choice systems in urban districts have become much more, there are a lot more districts that have that. So, of course, whenever you have a choice system, you get overchosen and underchosen. And if you've got a lottery system, then you're rolling the dice. So they're not perfect, but they do give parents an opportunity to visit schools. They do put pressure on schools to be competitive. And it's no longer open the door and they will come. You've got to be able to show that this school is good at doing this and that and enough to make you want to enroll your child there. So it's somewhat messy, but it has made a real difference in terms of equity issues and in an urban district, which is very, very diverse, the equity issue is huge.
How do you think, oh, sorry, go ahead.
I think that the competition thing is really important, but I think you have to have, in healthcare, we're going to come to a point where we have to have competition on 2 levels in order to drive value. First of all, we have to have transparency around quality, and increasingly that's coming.
But by that you mean what?
Well, mortality rates, complication rates, number of things that you do, long-term survivals, all that sort of thing. And they have to be risk adjusted, complicated, but you have to be transparent about it, and it has to be out there. And patient satisfaction is going to be out there. It's now public information, and it's drilled right down to the individual doctor. Mm-hmm. The second part of it is we're going to have transparency about cost. There is no transparency. Healthcare costs are the biggest black box in the world. I can't figure it out myself. I can't explain it to anybody, but it's incredibly complicated. We have, for example, 90 different contracts with private insurance. Then we have all sorts, there's going to be somewhere around 100,000 codes for different sorts of problems. And it is incredibly complicated, but transparency has got to come. It's like going to buy a car. It's great to say have a Mercedes, but on the other hand, you also want to know how much you're paying for it. And not everybody can afford it. So once you begin to have transparency around cost, and interestingly, it's coming. There's a company in California called Castlight. It's a startup company, and they're going into and be able to tell you how much it costs to go get a colonoscopy at any of the hospitals in California. And so now what's happening is employers are driving their employees to the place where it has the lowest cost. And so we need to have that kind of transparency. And with that, we're going to see plummeting of healthcare costs.
And you're keeping your own. I know that you've made a major investment at the Cleveland Clinic in electronic records. Is that correct? Isn't that part of it?
It certainly is. Over the last decade, we spent $1 billion in IT, and $300 million of that went to electronic medical record. So you can go to any of our facilities, and they're all connected. And the patients can have their own records.
Is that kind of transparency possible in a local school system, which is so political and so roots-oriented in some ways? Can you have that, or is obfuscation part of the deal?
Well, it's harder, I think, in the public sector where you've got an elected school board. And the biggest challenge with boards and superintendents often is that relationship, board-superintendent relationship. And so you have a certain degree of clarity, hopefully. The best day is the first day on the job you're starting anew, on where the line in the sand is, what you have the authority to do and what the board does. But often boards change during your tenure, and some of them get elected with the premise that they ought to get a new superintendent, and you get out in time and go somewhere else, hopefully, which I did. That was a move from Eugene, Oregon to Oklahoma City. But anyway, it's a lot harder to get that. As we go to charter schools, we haven't talked about those, and I lost about 4,500 kids to charter schools during the 10 years I was there, but I also started what were called pilot schools that were like in-district charters, which we ran inside the district and kept another 5,000 parents in the district because they had those choices inside. So it was the competition again. The culture in a lot of places is not competition. They're afraid of it. But you've got to get out there and be more vigorous about trying some new things and seeing if they work, and then pull the plug if they don't work. That's the other thing that's hard to do in education, is to pull the plug when it doesn't work. You can do that in central office, but teacher contracts and other employee groups and so on, it's very hard in that arena to pull the plug with lots of evidence and go into court to make the case.
You think it's hard to pull that plug? You ought to try closing a hospital. That's really fun.
Oh, well, hey, look, people get fired for closing schools. I've been through that. It's not unlike closing schools. All of a sudden, a worst performing school in the district becomes the best one for the people who are there.
I was requested to wear a flak jacket, by the way, by my security during the time that we closed the hospital.
Really? Where was this?
In Cleveland.
Really? Yeah. Sounds like the news business.
Well, we had a teacher.
You probably deserved it more than I did, though.
I did. I deserved it. A lot of people would agree with you.
Okay, when we had a teacher strike in Oklahoma, we had police protection at our house.
Well, I know you've taken some very controversial stands and brave stands, and I think one was when you denied the Boy Scouts access in San Diego.
Yes.
Can you tell us about that?
Yeah. I've always been a supporter of Cub Scouts and Boy Scouts using school facilities. Normally that's after school or later in the evening, and that was the arrangement that we had in San Diego. And there was an Explorer Post leader who was seen at a gay political rally in San Diego, and the Boy Scouts came unglued that he was involved with a scouting operation. So he was fired, and I'd gone through the time of you know, gay teachers and so on, and you know, so this was not brand new to me in terms of what was going on, and I took the position that the Scouts could no longer use the San Diego public schools during the time that school was in session. We gave them the last half hour of the day in the elementary schools for the Cub Scouts. And, you know, all hell broke loose on that one, and I took a lot of hits because the Boy Scouts were supposed to be wonderful, but I had gotten the board to agree that there was no discrimination of gay and lesbian employees as long as they were qualified to do the job and did it, and I hired them.
Beyond the flak jacket incident, have you done anything of that nature in terms of controversy?
Yeah. Well, the first, you know, when I became CEO, I sort of went through this sort of look in the mirror about healthcare, and I realized that I was in healthcare, but I never looked after a healthy patient. So I thought that maybe we ought to move towards wellness and trying to keep people healthy. So we started out on a sort of a gradual move. We banned smoking on all of our campuses, not just in the building, but across the entire campus, not in the parking garage, no place. And then we did a campaign for smoking cessation across the community and put on a smoking cessation program across the community and smoking cessation across all of our employees. And then I decided that, we decided, that was the point where my HR guy and I parted ways. He's not with us anymore.
Apparently you decided.
That we decided that we were not going to hire smokers. Well, that really brought the wrath of God down on our heads. But it's interesting now that it's beginning to spread across the country. Our biggest concern, by the way, was the fact that we're not going to be able to hire respiratory therapists, because it turns out that of all the people in the hospital, the #1 group as far as percentage smoking are respiratory therapists. Go figure. But it turned out that actually we haven't, so we test everybody coming in. We test them for drugs, we test them for cigarette smoking, and our incidence of smoking has gone down to about 8%. But across Northeast Ohio, across Cuyahoga County, which had a 28% incidence of smoking, it's now gone to 15% in 5 years, which is a huge change, which is lower than the national average. But you can imagine the political backlash there was to that, the newspaper and lots of places.
I'm getting a chirp, which indicates to me that it's time for questions. If I can turn off the chirp, which I probably can't. I'm having trouble seeing out there, but I know there have to be questions.
Yeah, I don't think we talk about the cost of healthcare. I think we talk about value for your healthcare dollar. And just like we do whenever we buy cars or whatever we do. So there's really sort of a group of things that are coming along in the future that are going to be changes in how we take care of people. First is wellness, which I just alluded to. And the dollars, for every dollar you put into it, you get 3 back. The second is a big change is going to be around the human genome. And we're going to, you know, all you have to do is read the paper on a daily basis and you see more and more discoveries coming around the human genome. And I dare say that within 10 years, every child being born will have a complete genome done at the time that they're born. And you can begin to predict that they have an increased incidence of atherosclerosis and coronary artery disease. Personally, I have to tell you that my biggest risk is for schizophrenia after being tested. So just saying. So, yeah, most people, first of all, the Congress wasn't going to touch this as far as tort reform, because you know most of Congress is lawyers, and that was off the table to start with. So that was not part of even consideration. It looks like at about 3% of the healthcare costs can be directly or indirectly attributed to tort and malpractice. And yes, you probably could slice off a couple of percentage with major tort reform. It certainly reduced our malpractice costs in Ohio to have tort reform in Ohio substantially. So my second approach was I decided we needed to do something about that. So we started out with the cafeteria and the food we serve our employees and our patients. And we made 40 changes in the cafeteria. I personally wheeled out the fryers. We took the trans fats out of all the foods. We took sugar drinks out of all the vending machines. You can't get a Snickers bar to save yourself. It's really terrible. And then we offered our employees open access to free yoga, free Weight Watchers, free curves, and free access to our gyms across the entire organization. And we have now lost, in 2 years, 300,000 pounds. Wow. The caveat is we probably got 3 million more to go.
Yeah, that's a big issue, and the local school district can do a lot to change that and has some control over what gets served. Where the tension comes in is between the federal government that provides some of the food and the dollars. And so you got this crunch between how you're going to pay for doing something that's a lot better, but that is happening more and more in school districts and their lunch programs, and hiring well, from a systems perspective, hiring a person who runs that whole operation that is 100% in terms of moving in the right direction.
And we've seen, just by the way, and I know you've seen this too, Tom, we've seen the correlation between grades and obesity in the grade schools.
Yes, indeed. Well, from my perspective, it would be very encouraging. For those of you who don't know, there are a lot of districts and states that have a provision in their contracts with the teachers that if there are layoffs, then the last teachers in, which are the newest and youngest and sometimes some of the best, get laid off first before mid-career or veterans. And so this is a pretty hot issue. The unions are going to fight it very, very hard. Now, in fairness, and I've got to take some responsibility for this, a contract doesn't get negotiated until completed until both sides agree. So a lot of this stuff has gone in contracts over the years, and some of them I've participated. But that's number one on a lot of people's list to get rid of. That would give much more flexibility and be better for kids.
Okay, well, let me talk a little bit about the political reality at the time the bill was the fashion, because this discussion went on at Kennedy's committee at the time. And it was very clear that we were not going to go to a single payer. But things are clearly in place going forward that we're going to be moving more and more towards government pay across the board. So here the statistics right now are 50% of health care is paid by the federal government. And the prediction is by 2025 it's going to be 75%. And if you look at what's happening in insurance companies being held up as the villain, and they are gradually being taken out and reduced, their influence substantially. There are now a lot of things in place which will drive increasing number of people to government pay. For example, right now the penalties for not providing insurance for your employees is a third of what it would cost you to pay for their health care insurance. So if you take a company like GE, that means essentially savings of about $3 billion. Now, $1 billion here, $1 billion there, pretty soon most CEOs you talk with have done the numbers, and they realize that they're going to save a lot of money by not covering their employees any longer. That will drive an increasing number of people to federal health care payment, and that is going to increase the percentage of people that are being paid for by the federal government. So what you're seeing essentially is incrementalism to getting to a one-payer system.
Sure. Yeah. And one of the big variables is the hard-to-fill fields. And so you've got huge pools in most places of elementary teachers and some middle school teachers, but when you get into some middle school and high school where you need good math and good science people, then it's a challenge. And the other thing that a lot of people don't realize when they say, well, why don't you do a better job with this? It's where you can't recruit enough people who are qualified to come in and take the job. And whenever your school system opens, whether it be the end of August or early September, there has to be a teacher in every classroom. And so you've got to do some default to get through some time where you can perhaps find some others and get much more aggressive on your human capital strategy and going out, particularly in the public districts, and recruiting in the hard-to-fill fields.
Yeah, the question is about nurse practitioners, and what you're going to see, the question is really who's going to take care of us all. There's going to be a shortage of doctors, probably about 60,000 short as we look at it right now. There's shortage just in Williamstown, for example. So
why is that?
Because there's more people coming into the system there are than there ever have been. We've never been a producer of doctors that are enough to fill our needs. We've always been a net importer of physicians from around the world, and now the State Department is making that increasingly difficult. And secondly, there are opportunities in other places in the world for doctors to stay. So you're not going to see the big influx that we saw from India, for example. There's now opportunities other places. So we're going to have a shortage of doctors, and that's going to be filled by nurse practitioners and nurse clinicians. Then there's a shortage of nurses. And that's going to be probably, it's not as bad now as it was because during the recession, all the retired nurses came back to support the family. And so that is not as big a problem. But looking ahead, there'll probably be a shortage of about 1 million nurses. And the problem is that there's a nursing shortage all over the world. So you can't import them. So who's going to take the place of the nurses? And that's going to be replaced by technicians. Now, this is not such a terrible thing. I was surprised when I went to the Cleveland Clinic that we had all these corpsmen that were helping us in cardiac surgery. They were the stability of that cardiac surgical service. We currently have 12 cardiac surgeons doing 4,500 operations a year and 80 physician's assistants. So the surgeon gets to do surgeon work, and you don't have to go change dressings, pull tubes, you take stitches out, all that sort of stuff. That's all done for you. So it makes everybody practice at the top of their licensure. So we're going to see increasing amounts of that sort of thing. And you're also going to see where you get treated is going to change. For example, I was talking with the CEO of Walgreens the other day. They have 7,500 outlets across the country. They're taking the pharmacist out from behind the counter. He is giving shots now. He's making follow-up calls to see if people take their medications. And, you know, I said to them, "Do you think about having an insurance arm?" And they said yes. So you're going to see tremendous disruption in who provides your health care and where you get it. There's going to be new players coming in that we haven't seen. CVS, we've got 9 physician's assistants right now in CVS. So maybe you get your immunization and your strep throat done at CVS. You go to outpatient to get your annual checkup. You go to the community hospital to have your baby, and you go to a big center to get probes put in your brain for Parkinson's. I'm well aware of that, and I think that that is a solution that is reducing the demands on the individual doctors and helping them financially. I think the bigger issue, I think, is the fact that now increasingly doctors are going to be employed. 60% of the doctors across the United States are now employed. And everybody, not everybody, 90% of doctors coming out of medical school want to be employed. And with now 50% of the graduates being women, they want to have families, they want to have hours, they want to have a practice shared, and so they're going to be employed. So you're going to see that most of the doctors are going to be in some sort of employment arrangement, and I suspect it'll go to 75 in the next 5 to 10 years.
Tom, I'm going to have to try to start wrapping this up, and I want to know, Tom, Toby just told us what he thinks of what it's going to look like in the next few years. What do you think public education is going to look like 25 years from now?
25 years out, that's a hard call. We were talking about technology earlier. I think technology is going to have an impact and is already starting in the public school sector. And yet, I agree with the comments that have been made that there is no substitute for that in-person kind of connection with people who are responsible for teaching and from whom you want to learn. I'm not anti-technology, but I don't think that is the answer. Extended school days. I think that's going to be an important issue. It's a cost one, but Boston, we had a tough time trying to expand them. It's only a 6.5-hour day. And particularly in urban districts where kids need a lot more support, they don't have the out-of-school time kind of thing. I see that coming as an important piece, and also having less vacation time. If I were a czar, I would make teaching a 12-month position. That would allow time for summer programs, a nice Christmas vacation, maybe a spring week break, and a couple weeks in the summer, but that would make a huge difference. And the other thing, just quickly, because I know we're out of time, we started a program, we had a choice to make. There were a lot of kids that did not have the graduation requirements met to graduate, who had to work in the summer. So if they got summer jobs, then they were going to get further behind and not their make-up courses. And we got some of the big employers in Boston to have what we call classroom in the workplace. And they said, the first 90 minutes of the day, you've got them. We sent Boston Public School teachers in to do English language, arts, and math for the first 90 minutes of the day. They worked the rest of the 8-hour days, and the employers paid the kids for 8 hours. So, I mean, there are things like that that you can come up with that can really make a difference, and particularly for those who need the greatest amount of support and don't get it elsewhere, but in what the schools can offer.
Can you take us out 25 years?
Yeah, if I live that long. Well, first of all, I don't think I can take it out 25 years, but I think what's coming is the same thing that we've seen. There's no longer a mom and pop corner grocery store. There's no longer your community bank. Accountants and lawyers no longer have single practices, and I think we're seeing the same sort of a revolution come to healthcare. And right now, there are strings of hospitals across the country with 150 hospitals owned by one group. So I think you're going to see a consolidation of hospitals. I think you're going to see care move from hospitals to outpatient to home care to preventive care. Each one of those steps will decrease the cost. I think you're going to see physicians employed, and I think you're going to see increasing number of people who are supporting the physicians. I think that at the end of the day, regardless of whether we think it's broken and not perfect, every country in the world is dealing with the same issues that we're dealing with. And nobody has got the answer to this. In Europe, you see people going to privatizing. In the United States, we're going just the opposite direction. So we're all struggling to find what the system is, but we have to take cost out of the system, and I think the way to do it is to organize it, have it more collaborative. We just built, for example, a $170 million data center. Not every hospital wants to do that or can afford to do that. And so you have to have that whole back office aspect of things. You got to spread it across just like you did in supermarkets.
Well, I think you can see that thanks to the class of '62, we're in pretty good hands in terms of health and education.
And the media.
Thank you.